Thank you very much. And the next presenter is Stefania. Thank you very much.
Okay, so good morning again. First of all, wholeheartedly congratulations to Peter, whom I'm very lucky to work here. Thank you for having me in your team. I think it's a great opportunity and I grew a lot with you here. So I'm very lucky to have two of my mentors here. Thank you and congratulations and happy first 10 years anniversary. So my talk today should be about the prognostic role of circulating exosomes in pancreatic adenocarcinoma. Oops. And yes, thank you. Well, thank you. We are talking about pancreatic cancer a lot, and we've seen that the incidence is increasing, and in the EU, it is expected that by 2040, it will become the third leading cause of cancer-related death. And we know about the dismal prognosis in this disease with a 5 years overall survival of 6 to around 25%, but the 25% is for the stages that for the early stages of diagnosis and that are managed in high research, high expertise centers. By comparison with all cancers, survivals at 5 years, which can be around 67%. And we learned that the reasons behind this poor prognosis are the advanced stage of diagnosis, 80% of cases, tumor is unresectable, the high recurrence rate after treatment with curative intent, and this recalcitrant tumor behavior with a high treatment resistance. And we have some tools that guide disease management that we use, but they have some limitations. The contrast-enhanced CT scan don't work so well with small lesions, and we've seen that the CA99 has some problems as well. It's not tumor specific, and maybe it's not secreted in up to 15% of the population. Therefore, it is indisputable that we need, on one hand, a method for earlier detection of this disease, and this has been thoroughly addressed these days, but also a tool to help us to better stratify indication for treatment in these patients. And in this background, performing liquid biopsy for comprehensive molecular profiling is of course of great interest, because tissue acquisition in pancreatic cancer is not without morbidity, and also it is not really suitable for serial analysis as we would need for disease follow-up. And among the analytes that are available for performing liquid biopsy, we have the exosomes, and I'd like to talk a little bit about them. So they are small extracellular vesicles of endosomal origin, which are extensively involved in the intercellular crosstalk, both in physiological and pathological processes. Although when they were first discovered 40 years ago, they're thought to be means of clearance of intracellular debris. Now we know that they are involved in aging, inflammation, obesity, cancer. And their biogenesis is relevant for their properties. It starts with the formation of an early endosome from the plasma membrane of the parental cell. And afterwards, they become multivesicular bodies by becoming populated with intraluminal vesicles. And these intraluminal vesicles are formed by the inner budding of the endosome membrane. And during this process, the intraluminal vesicles are loaded with a vast variety of molecules, nucleic acids, proteins, metabolites, lipids. And eventually they are released in the extracellular space, and they act specifically on target cells, either in autocrine or paracrine manner, or distally, where they travel through different body fluids. And their cargo reflect the phenotype of the parental cell and also the state of the parental cell. And it's stable in the extracellular space because of the lipid membrane that the exosome has. And of course, it is used to influence the behavior of the target cells. Now, in pancreatic cancer, as in other cancers, the production of exosomes is increased. They modulate tumor microenvironment. They interact, tumor-derived exosomes act on pancreatic stellate cells, cancer-associated fibroblasts, and induce desmoplasia. And we know that desmoplasia, on one hand, is associated with hypoxia, which leads to treatment resistance, but also to a metabolic change in the metabolism of the tumor cells. And what's interesting is that it's a bidirectional communication. The exosomes derived from the fibroblasts deliver to the tumor cells metabolites de novo so that they can support their carbon metabolism. They are involved in inducing an immunosuppressive environment in the tumor by inducing M2 polarization of the macrophages, activation of the myeloid-derived suppressor cells, by inducing some lymphocyte dysfunction. They're involved in neoangiogenesis, lymphovascular invasion, and metastasis by acting on pre-metastatic niche formation by the interaction with the fibroblasts in the target organ and inducing their pro-inflammatory signaling. And also they are involved in epithelial to mesenchymal transition. Therefore, exosomes seem to be a platform of biomarkers that can thoroughly characterize the tumor and that are available in the peripheral blood. Therefore, we decided to perform a systematic review on the prognostic role of exosomes in PDAC. And you can see here our search and selection process that was done in 2021 in January in these databases with key terms related to, of course, pancreatic cancer, extracellular vesicles. And we decided to include in our papers those studies reporting in differences in overall and progression-free survival in PDAC cases according to the status of the exo biomarkers. And from the roughly 2,000 papers that we were able to hit with our search key back then, we found 18 eligible for the systematic review. And since all of them were reporting on factors known to be involved in tumor development and associated with tumor aggressiveness, we considered it's good to do some meta-analysis on some of the available data. And I'd like to present some of our quantitative results. In the plots in the upper part, you will see the analyzed population. And in the lower part, of course, the pooled results and the outcomes that we associated. And first, we looked at the association of the exo biomarkers in the peripheral blood and overall and progression-free survival across various stages of PDAC. Sampling time was at baseline whenever it was reported, and it seemed that these patients with highly expressed exo biomarkers had a poorer prognosis with decreased overall and progression-free survival. Now, to decrease heterogeneity, but also to increase clinical relevance, we tried to perform some subgroup analysis. And first, we looked at tumor resectability. And we perform a subgroup analysis on resectable cases. And what we can see that patients that have high exo biomarkers before surgery have a decreased overall survival. Now, for the unresectable disease stages, well, besides the low number of patients in the subgroup, but which characterizes most of our analysis, we have also a discordant result. And you can see here the exo biomarkers that were actually analyzed in each of the studies. And the only conclusion that we can draw here is that if exo-KRAS mutations and concentration of exo-EpCAM are associated with mortality in unresectable PDAC, then the concentration of exosomes in the plasma were not. And the other subgroup analysis that we could perform was on the type of biomarker, and specifically we could look at microRNAs. We know about microRNAs that they are short nucleotide chains acids, that they are involved in a gene expression modulation in a post-transcriptional step by acting on the messenger RNA and on the protein synthesis. And what we found here that across various disease staging, higher expression of some exomicroRNAs is associated with decreased overall survival. And these were sampled at baseline. Regarding progression-free survival, one of the papers that we were able to include in the systematic review reported on that. They were resectable cases, and they showed that a higher expression of XMIR401A was associated with decreased progression-free survival. These were our quantitative analysis. what about the possibility to use exobiomarkers for longitudinal monitoring, for serial sampling to see treatment efficacy? And there is this group from MD Anderson that looked at exo-KRAS mutant allele fractions and the change from baseline during therapy from the peripheral blood. They looked at localized disease stages, and what they saw was that after neoadjuvant treatment, a decrease in exo-KRAS mutations was associated with a significantly high odds of resection. While for the metastatic cases, they selected for the analysis those cases that had at least 2 restaging imaging evaluations, and that they had at least 2 blood samples drawn and sufficient follow-up time, median of 200 days. And what they saw was that a peak in exo-KRAS above 1% during serial sampling appeared in 80% of the cases with disease progression and in none of the cases without disease progression. And that this peak in exo-KRAS appeared with 50 days, median of 50 days before this progression was detectable by imaging, and detection by imaging corresponded with an increase of CA99. Now, can we use them as predictors of treatment response? A group from Japan showed that a higher expression level of XMIR21 and XMIR401A at baseline was seen in those cases that had disease progression during chemotherapy by comparison with the cases that had disease remission or stable disease. And there are similar other results in the literature on this cohort of 177 unresectable PDAC stages that received gemcitabine-based treatment. High expression of MIR21 was associated with short time to progression and decreased overall survival. And MIR401A was considered a tumor suppressive MIR for other tumors like urinary cancers, like colon cancer, like hepatocellular carcinoma. But in the literature, the results are consistent. It seems to be an oncomir in PDAC. There's an interesting result from another group from Japan that thought, what if we compare the exosomes in the portal blood with those from the peripheral blood and see what can we rely on regarding disease recurrent after surgery for resectable cases. And they had 55 cases. They performed the sampling immediately after laparotomy before resection. And they saw that the portal blood exosomes performed better in predicting recurrence of the disease. And they argued that this was because of the tumor, the pancreas proximity, which ensured an enhancement of the tumoral-derived exosomes. Now, to sum up our finding, I would say that our pooled results, our numbers that we show, are not the strength of our review, because one could correctly argue that they have a lot of heterogeneity, and I agree. And I dare to say that the heterogeneity is actually informative in itself, because maybe it shows the directions in which we can perform more research to bring the exosome closer to clinical praxis. In the studies that we included, the population was heterogeneous, various disease stages, various types of treatment. Biomarkers, of course, varied across the studies, but also the detection methods. And there is some guidance regarding performing studies on extracellular vesicles. We have the International Society of Extracellular Vesicles, and they make clear recommendation regarding the nomenclature that should be used, that the experiments should be replicable, how to perform functional studies, that we should report the results on the available databases. And what we also need for bringing them closer to clinical use is a workflow simplification to bring them closer to common laboratory equipment. Because what could be the perspective of using them on a daily basis? Well, maybe a more accurate and early diagnosis of lack of treatment response, we could adjust accordingly. And also a better treatment stratification for the patients. We could maybe choose better those patients that could benefit from a major surgical intervention, and also those that could actually benefit from chemotherapy. And this should eventually reflect on survival and quality of life of patients, and hopefully on healthcare costs. And because I talked about perspective, and this is not related to our review, but I cannot end my talk without bringing it up. This is a new dimension in theranostics. So drug delivery systems, they have been brought to discussion these days. Well, exosomes can be harnessed and trained and loaded with bioactive molecules and with chemotherapy and made to target specifically tumor cells. And here you can see a schematic representation of a study performed by Kammerkar and colleagues who loaded fibroblast-derived exosomes with short interference RNA, and they managed to decrease KRAS signaling both in vitro and in animal models. And there is now a phase 1 clinical trial on metastatic PDAC patients that are resistant to treatment for this kind of approach. And there are other studies in the literature that have proved the benefits of exosomes loaded either with paclitaxel or a combination of paclitaxel and siRNA, and they prove their efficacy in vitro and in animal models. And the exosomes are good should be good as drug delivery systems because they naturally evade immune detection, they cross blood barriers, they have intrinsic homing capability, and they should have increased in vivo action. Nevertheless, their production is with low yield, high cost, and laborious and lack standardization. And with this, I'd like to thank the team for their implication and support, and thank you for your attention. And I'm happy to take questions and remarks.
Congratulations, Stefania. My opinion, one of the best presentation with a good presentation. Thank you. Bravo.
Thank
and
you.
Please.
Stephanie, congratulations for your beautiful paper, actually. But I would like to be interested in the increase of exosomes after the needle puncturing with US or anything else, because evidently that would be the interesting things about the need in seeding the cells after FNA or other needle.
Indeed, there is data in the literature about the increase of exosomes, about the increase of KRAS, that it can have a peak after FNA and FNB, but it's not yet certain that this can lead to metastasis. Nevertheless, the worry would be rather the seeding of the needle tract. For the circulating exosomes, I'm not quite aware if there is this information, the association on seeding on the needle tract, but it's an important aspect, and it's important to think about it and to look at it.
Stefania, I have one question. What is your opinion? Exosomal biomarkers are better option than the cell-free DNA?
Yeah, well, I had the chance to work a little bit with cell-free DNA in Bucharest, as I said, and cell-free DNA is great and it's already used in some cancers. And why bother with exosomes, which are more complicated and more expensive? Well, with cell-free DNA, the overlap with the tumoral changes in the genetic alterations ranges from 50 to 60% to higher percentages, to 90% overlap. Moreover, in cell-free DNA, we can look at mutations and at epigenetic changes. But on the other hand, in the exosomes, we can see a wider variety of biomarkers that can better reflect tumor behavior and that could give a better overview on the tumor stage and on what we should do maybe. It could bring this opportunity of a multi-analyte marker from a single blood draw. So this is why I decided to look at it.
Thank you very much, and it's a great pleasure for me to introduce immunotherapy. Thank you very much.
I have one more question to just a very quick one to Stefania. When are we going to start to use these markers targeting?
It would be, I think we discussed a lot about this. This is a long shot. We should make a lot, because it's difficult, it's expensive, it needs optimization. It needs standardization, but we should work on it because the perspectives are indeed very promising. And yes, we should start looking at them.
So you have to think about timelines, weeks, months, years?
Years. I don't have an answer yet. Thank you.
Maybe tomorrow.
Maybe tomorrow. Thank you.